So we just had a lot of fun talking about hypoxia. Well, at least I did. So let's remember again that hypoxia was the most common cause of necrosis, right? So I'm going to ask you again, what's the most common cause of hypoxia? And I'll give you a hint. The answer's on the screen. That's right, it's ischemia. Okay, so ischemia, the definition again was a decrease in blood flow, right? So now we're going to talk about what tissues are most susceptible to a decrease in blood flow. And to just help you out a little bit, two things to keep in mind for this. The susceptibility of tissues to ischemia will be determined by the tissue's metabolic activity, how much ATP and oxygen and thus blood flow it will require, and the vasculature. And specifically, does this tissue have what are called watershed zones? And those are where two blood vessels are coming together. There's an area right here that is actually susceptible to ischemia because sometimes these two blood vessels don't perfuse and share their blood very well. They're selfish. So that is called a watershed zone. So just keep these two things in mind as we go through them. We'll start off with the GI tract. Where in the GI tract do you think you could run the risk of ischemia? The first answer is the splenic flexure. Where two arteries come together, we have a watershed zone here. What two arteries come together right there? The superior mesenteric artery, very good, and the inferior mesenteric artery. Awesome. Remember, the superior mesenteric artery supplies most of the small intestine and the colon up to right here. The IMA supplies the rest of the colon. Very, very good. Okay, where else do you think? And real quick, by the way, what do you think this patient would present with if they have some ischemia taking place right here? Well, pain right there, right? So pain in their left upper quadrant. And pain, when? When would they experience this pain, do you think? Probably pretty soon after eating, because all this colon is going to need to peristalse the food, and then it will require more energy, more ATP to do that. So with less blood flow here, if there's like a narrowing or a clot in one of these vessels, then there will be a decrease in blood flow and pain and angina right here to this tissue. That is called ischemic colitis. And if some of these cells die, they'll slough off and actually lead to, can you think what I'm going for here? Bloody diarrhea. Awesome. So where else in the GI tract do you think you could run the risk of ischemia? How about the rectum? Again, where we switch over from two blood vessels. There's the superior rectal artery and the middle rectal artery. What branch is the superior rectal artery off of? Actually, the inferior mesenteric artery. What about the middle rectal artery? The internal iliac artery. So there's a nice little anatomy tie-in there. Okay, great. So let's move on to the heart now. So we see some necrosis taking place right here. So obviously this tissue is susceptible to ischemia, but what part of this tissue is most susceptible? To answer that question, let's think about what supplies the heart with blood. The coronary arteries, right? Right. What will be most susceptible? It's easy. What's farthest from the blood supply? That's going to be most susceptible, and that is actually the subendocardium, right underneath the endocardium. That's kind of odd to me, at least, because this heart is pumping gallons and gallons of perfused, oxygenated blood every day. Yet, right underneath the surface, there's tissue that's most susceptible to ischemia. So it can't even supply its own self with all this blood that it pumps to the whole body. So, what actually do you think is the coronary artery that would have supplied this area and that was occluded? That would be the most common one to get occluded, and that is the left anterior descending. Very good. Okay, so how about, well, don't look for 1 second. What tissue is most susceptible to hypoxia, global hypoxia, in a person's body? That would be the kidney. Very good. Thanks for not looking and being honest about answering that question. So here we have a subunit of a kidney, which is called, just trying to keep it interactive here, it's called a nephron. Very good. So what parts of this nephron do you think will be most susceptible to ischemia? Well, for this question, let's think about what parts of it will be most metabolically active. So the proximal tubule for sure, right? More than 60% of everything is reabsorbed in the proximal tubule. You can think of all those ATP requiring pumps, pumping ions back into the bloodstream. So that's going to require a lot of energy, and if there's a decrease in blood, that will be hit hard. Okay, we can think about that. Where else in the nephron? I'll give you a hint. The next area is impermeable to water and sets up the concentration gradient for the kidney. That's right. The thick ascending limb of the loop of Henle. It's impermeable to water, and it has all those pumps. Do you remember what ions they pump? The sodium, potassium, 2-chloride pumps. And they actually generate and set up the concentration gradient in the kidney. Very good. So, here's another little random question. What would this person's urine look like if they're sloughing off dead cells? What type of casts would they have? They would have muddy, brown casts in their urinalysis. Very good. Just trying to integrate some more things to help you out. Okay, so now let's move on to the brain. Ooh, we see a nice little infarct right here. This is another watershed question. So, what two arteries are on either side of this watershed zone? How about the anterior cerebral artery and the middle cerebral artery? They don't share this region right here very well. And so it infarcts. So right here is where the infarct is. What would this person's symptoms present as? They have a stroke on the left side of their brain. To answer this, let's go back to our homunculus. Remember that? So a very nice drawing here by me. There's the feet and the trunk, and then there's the upper limb, and then finally there is the face. Little eye, little smiley mouth. Actually, he'll be sad because he's having a stroke. So, so therefore, we can expect, and maybe this upper limb would come down a little bit lower. We'll expect some facial symptoms and maybe upper limb symptoms, but it will be on the right side, right? Because everything's crossed in the brain. So if it's a left infarct, it will be on the right side of the body. All right, so let's move on now to the liver. All right, so in the liver, blood comes from this portal tract, or this portal triad. And portal triad, that's another name for this. It means three, right? What three things comprise the portal triad? Well, two things are flowing into the liver. Those two things are blood in the form of the portal vein and the hepatic artery, which is a branch off of what artery? The celiac, right? Celiac trunk. Very good. And then the third part of this triad is flowing out of the liver, and that is bile. Okay, so here's where all the blood's coming in, and just like with the heart, the part farthest from this blood supply will be most affected by ischemia, and that will be the central vein, because that's where all the blood drains into. So oxygen comes in here, it gets used up, and as it trickles into the central vein, we'll have less oxygen available. Now, we're going to talk about how this damaged tissue will appear grossly. And just to recall again, the microscopic term for this death due to ischemia and massive cell death is called necrosis, right? But the term to describe the gross appearance of this tissue is infarction. Okay. When you don't need a microscope to look at it, that's an infarction. Just two fancy terms. So, is this infarction going to be red or pale? And if it's red, what do you think of when you think of red? You think of blood, right? So that's basically it. Is there a good blood supply to this dead tissue where it can kind of trickle in from another source to cause this damaged dead tissue to appear red or hemorrhagic? So here's the lung here, and we see this wedge-shaped infarct. We see it's pretty red appearing, right? Pretty hemorrhagic. Why is that? Well, that's because there's two blood supplies to the lung, right? Right. So we're talking about red infarcts here. So the two blood supplies are what? The pulmonary circulation from the heart. Okay. What's the other one? How about that bronchial circulation? Where's that from? Like the thoracic aorta and the intercostal arteries? Yeah, that blood can trickle in and actually cause this dead, damaged tissue to appear red and hemorrhagic. Good. So where else in the body can we see this? Well, what other tissues are very well perfused? How about the liver? And how about the bowels too? Now let's talk about some pale infarcts. Where would we see these? So we'll see these actually in tissues that aren't as well perfused. Makes sense, right? So tissues like the kidney, where there's only one blood supply, branches out, okay? But there's no other blood supply to trickle in and cause this dead tissue to appear red. So it won't fill up with blood. So that's called an end organ blood supply. Some other examples are in the spleen and even the heart. The heart's a little special because it can actually undergo something called reperfusion injury. Whoa, what's that? What do you mean by reperfusion? How can that happen? We have a blood vessel here, okay? Let's say we have a clot. Oh no. So the tissue downstream will be subject to necrosis, right? And appear as an infarct, and a pale infarct at first if we're talking about the heart. Okay, so that tissue will be dead, and blood will not be able to flow and not be able to give this tissue oxygen, causing it to necrose. But we do have natural things that can actually dissolve clots in our body, like, do you know? Tissue plasminogen activator, which will grind up this clot sometimes and actually allow blood to resume flowing. However, this tissue has been damaged because it hasn't received blood and oxygen and ATP. So it'll be damaged, and actually neutrophils are called in and attracted to damaged tissue. So neutrophils will come in and do their thing. We'll talk about that in a little bit. But because this tissue is damaged and there's gaps in the endothelium, blood can actually flow in too. So this once pale tissue will actually become red. Very good. So here's the thing with reperfusion injury. Neutrophils release, what do they release? Reactive oxygen species. Very good. And do you think that they're specific in their killing? No. They don't only target bacteria and viruses. They just release these reactive oxygen species to take out everything in sight, even healthy tissue. This damaged cardiac tissue that has dead cells in it. Some of them are almost dead, not all the way, but when neutrophils come in and release the reactive oxygen species, that'll cause even more damage and more harm. That's called reperfusion injury. And that's important for the USMLE. All right, shock. That's our next topic. And this is actually another type of ischemia, believe it or not. Ischemia, again, was a decrease in blood flow. Shock is a massive decrease in blood flow to the whole body. Whoa! And there are two main types of shock, either hypovolemic/cardiogenic or septic. All right, let's talk about hypovolemic cardiogenic first. And we're going to compare these two by looking at the cross-sections of blood vessels. Neat, right? So let's talk about this one first. And you can think about the names, right? Hypovolemic, low volume, so low blood volume. And cardiogenic, there's something wrong with the heart. Okay, so for both of these, if there's something wrong with the heart, that's going to cause less blood flow downstream from the heart, right? And if there's just a low blood volume due to like hemorrhage or something, then there will be a low blood volume. So that's the main problem with this one. There's just a lower amount of blood volume. We're going to talk about now three main parameters that are affected. Why would we do this? Well, because the USMLE will ask you this, so that's a pretty good reason. So the first parameter we'll talk about is cardiac output. How will this be affected when you have a decreased blood volume? So remember, this is heart rate times, what's the formula for cardiac output? Heart rate times stroke volume. Very good. So which of these two will be affected? Stroke volume, right? That's going to be down because there's a lower amount of blood. So what will that do to the overall cardiac output? I wonder. Decrease it. Very good. So with a decreased cardiac output, that will actually affect the total peripheral resistance in the body. And this is basically how constricted are blood vessels. What do you think is going to happen with this one? Well, let's think. With a lower cardiac output, not as much stimulation will be acting on those receptors, like those chemoreceptors and baroreceptors in your carotid sinus, right? Right? So, that will in turn stimulate the release of massive amounts of adrenaline and norepinephrine, which act on what receptors in blood vessels? Do you remember from physiology? Alpha 1 receptors to cause constriction. So the total peripheral resistance will be increased to try to compensate for that lowered blood pressure and lowered blood volume. Your body will constrict your blood vessels to increase your blood pressure and to increase perfusion. So cardiac output was down, TPR was increased, and VO2, which is really the amount of oxygen returning to your heart, what do you think will happen to that one? Well, let's think about that. If you're going fishing, let's draw a little fisherman here. Beautiful drawing, just absolutely gorgeous drawing here. If you're going fishing in a river where the amount of water flow is decreased and there's less fish, which will have the fish symbolize red blood cells carrying oxygen, there's less fish in there, then there's going to be a less flow and you'll have more time to catch the fish, right? So you'll try to extract and catch as many fish as you can, and that's what your tissue does. It catches as much oxygen as it can possibly catch before it returns to the heart. So the amount of oxygen returning to the heart should be decreased. So that's what we have there. Very good. So let's now talk about septic shock. Sepsis implies an infection. Usually there's an infectious source, like a bacterial product or virus or something, that will actually cause massive inflammation. So if you remember, I'm going to ask you an immunology question now. What pathway is activated by bacterial products? The complement pathway, right? Very good. So if there's bacteria throughout someone's body, complement will be activated. What two products are responsible for vasodilation? C5a, think of the A for anaphylaxis, and also C3a. Very good. So these will carry out anaphylaxis, and that basically means massive vasodilation throughout this person's body. And that's not very good for blood flow, actually, because we can think of this fisherman again. Here's his little legs, here's his arm, head. All right, this one looks a little bit better, maybe. Fishing pole, he's fishing. We have him downstream from a dam. These gates of the dam were lifted so that water will just be rushing through very, very fast. And these poor little fishies will just be flying through. Do you think this fisherman's going to be able to catch any of them? No. He's sad. Poor guy. So just like he can't catch the fish, your tissues won't be able to catch the oxygen because the red blood cells will be flying through the system and returning to the heart unscathed. So, because they'll be flying through, what do you think will happen to cardiac output? Well, there will be an increase in stroke volume, so the cardiac output will be increased. TPR, what do you think will happen to that? Because of this vasodilation due to these anaphylotoxins here from the complement cascade activated by bacterial products, you're going to have a massive decrease in TPR because of the vasodilation, less resistance. The amount of oxygen returning, because you can't catch any of that oxygen, it will be increased actually, or normal, returning to the heart. So that's how we can compare them. For hypovolemic and cardiogenic shock, cardiac output was decreased. TPR was increased. VO2 was decreased. And for septic, CO was increased, TPR decreased, VO2 increased. So there you have it. There's the comparison, and that's what's going to be asked on your multiple choice USMLE exams. Well, now it's time, for another flash quiz. How would you expect these patients, both of these types of patients, to appear? Well, let's think about it. For hypovolemic cardiogenic shock, what do you think? So they have less blood volume, so they'll probably be pale. And because you have all of that norepinephrine and catecholamines vasoconstricting, that'll lead to them being pale and also sweaty, so they'll be a little bit clammy too. So cold, cool, and clammy and pale. like we see here. And this was probably in a patient with a cardiogenic shock because all of the blood backs up behind their heart and into their lower extremities, which is where we get, what's this called? Pitting edema. All that third-spaced fluid. How about septic shock? How will they appear? Well, let's try to guess. So with all those bacterial products released and complement activated, C3A, C5A, we will have vasodilation, so they should be flushed, warm and flushed, just like we see here.